Restrictive Cardiomyopathies. ZA Lecture Series. Author, Jennifer Giuseppe, MD. Series Editor, Eli Gelfand, MD, FACC. Objectives: Introduction, Symptoms, Causes, Diagnosis, Treatment Options. Myocardial. Endomyocardial. Diagnosis. ECG. Echocardiography. Invasive hemodynamics. Cardiac MRI. Treatment options. Introduction: Least common type of cardiomyopathy. Increased stiffness of the myocardium, impaired diastolic filling. Ventricular volumes are usually normal or reduced. Wall thickness is normal or mildly increased. Systolic function is typically preserved. Symptoms, similar to HF due to other causes. Volume overload. Fatigue. Dyspnea. Orthopnea. Nocturnal dyspnea. Arrhythmia, palpitations, syncope, exercise intolerance. High-grade avenue block, sarcoidosis, amyloid greater than hemochromatosis. Atrial tachyarrhythmias, including atrial fibrillation. Ventricular tachyarrhythmia. Reduced cardiac output. Exercise intolerance. Cognitive difficulties, etiologies. Myocardial causes, including infiltrative disease, are most common in the U.S. Endomyocardial causes, specifically endomyocardial fibrosis, EMF, more common outside of U.S. Leading cause of death in Africa, India, South and Central America, and Asia. Unclear primary cause. Possible association with eosinophilia or nutritional factors. Endomyocardial biopsy of a PT with EMF. http://www.hefsa.org/images/ever_big.jpg. Myocardial causes: infiltrative. Amyloidosis. Can be primary, secondary, senile, or familial. Secondary is associated with multiple myeloma. Cardiac sarcoidosis. Rarely isolated, usually in concert with lymphadenopathy, parenchymal lung disease. Can present with syncope from ventricular tachycardia or block. Avenue conduction abnormalities, typically progressive, so low threshold for pacing plus/ICD. Gaucher disease. Fatty infiltration. Myocardial causes: storage diseases. Hemochromatosis. Therapeutic phlebotomy often reverses cardiomyopathy. Fabry's disease. Glycogen storage disease. Deficiency of alpha-galactosidase A. Enzyme replacement is available. Testing is free. Endomyocardial causes. Endomyocardial fibrosis. Hypereosinophilic syndrome. Carcinoid heart disease. Metastatic cancers. Radiation. Toxic effects of anthracycline. Drugs, serotonin, methosergide, ergotamine, mercurial agents, busulfan. ECG findings: large P waves indicating biatrial enlargement. Conduction delays. Various SD and T segment changes. Ventricular tachycardias. Especially in sarcoidosis. In amyloid, classically, low QRS voltage. Echocardiographic findings. Non-dilated, non-hypertrophied ventricles. Unless infiltrative or storage disease. Moderate to marked biatrial enlargement. Doppler is required to assess impaired ventricular filling. Diastolic transmitral flow velocity, 4-chamber and short axis views. Nihoyanopoulos, P. et al. George Echocardiogra 2009-10:IE 2333I, DOI, 10.1093/Echocard/JEP156. Amyloid heart disease. Marked wall thickness, 15 mm, concentrically. Homogeneous texture of both ventricles. Thickening of the mitral and tricuspid leaflets and right ventricle. M-mode and parasternal long axis. Nihoianopoulos, P. et al. George Echocardiogram 2009-10:I 2333I, DOI, 10.1093/Echocard/JEP156. Reduced left ventricular function. Note the markedly thickened RV free wall. Doppler findings. Normal systolic contraction with a rapid but ill-sustained ventricular filling seen on pulsed wave Doppler, E-wave, and with little or no late ventricular filling, A-wave. Top, mitral annular velocities demonstrating reduced systolic as well as diastolic velocities, E and A. Bottom, pulsed wave Doppler from the mitral valve demonstrating very high early diastolic velocity, E-wave, short deceleration time, less than 130 ms, low late diastolic filling, A-wave, of the transmittal velocity. Nihoianopoulos, P. et al. George Echocardiogram 2009-10:I 2333I, DOI, 10.1093/Echocard/JEP156. Cardiac catheterization. Square root sign, dip and plateau. In diastole, rapid early diastolic filling, dip, followed by a plateau during pressure tracings. Seen in both restrictive cardiomyopathy and constrictive pericarditis. From eMedicine article Pulmonary artery catheterization. http://imd.medscape.com/pi/emd/cab/cardiology/15003172323.jpg. Elevated diastolic pressures. Left ventricular pressures higher than right. Dependent on preload, can have normalization of pressures if adequately diuresed. Cardiac MRI. High diagnostic accuracy for constrictive pericarditis, which can present similar to restrictive cardiomyopathy. Important to distinguish from restrictive cardiomyopathy as definitive surgical therapy available for constrictive pericarditis. Gold standard for non-invasive diagnosis of cardiac hemochromatosis. Constriction versus restriction. Constrictive pericarditis. Physical exam, JVP elevated. Kussmaul's sign, lack of the expected inspiratory decline in JVP. Secondary to decreased compliance of the right ventricle. Pericardial knock. CXR, calcifications of the pericardium can be present. Echo, bulging of the septum to the left. Respiration variation in filling velocity. Inspiration decreases PCWP decreases pressure gradient for ventricular filling because no effect on ventricular diastolic pressure. Cath, equalization of pressures. Restrictive cardiomyopathy. Physical exam, JVP elevated. EKG, depolarization abnormalities, such as bundle branch block, ventricular hypertrophy, pathologic Q waves, or impaired avenue conduction. Echo, normal LV function. Minimal variation with respiration of filling velocity, inspiration decreases PCWP and ventricular diastolic pressure equally, no change in pressure gradient. Cath, both show dip and plateau. Treatments treat underlying disease in secondary causes. Attempt to maintain sinus rhythm. Atrial fibrillation is poorly tolerated. Amiodarone. Treat heart failure symptoms. Diuretics and ACE inhibitors. Avoid digitalis, nifedipine, ACE and verapamil in amyloid. Most are irreversible and require cardiac transplantation. Regardless poor prognosis, treatment for cardiac amyloid. Usually ineffective and generally consists of supportive measures. Autologous hematopoietic cell transplantation in conjunction with melphalan therapy. http://www.pathology.vcu.edu/education/cardio/lab3.g.html. Heart transplantation, used only if the patient has isolated cardiac amyloid. ICD placement, controversial given most sudden death is related to electromechanical dissociation, not ventricular arrhythmias. Treatment for cardiac sarcoid. Goal is to control inflammation and fibrosis. Glucocorticoids, thought to halt or slow process of inflammation and fibrosis. Dose unclear. Relapses common after taper. Chloroquine, hydroxychloroquine, cyclosporine, and methotrexate, can be used for patients that are resistant to steroids. ICD placement, 30 to 65% of deaths in patients with cardiac sarcoid are due to ventricular arrhythmias or conduction block. Treatment for other causes. Hemochromatosis. Treatment with serial phlebotomy. EMF. Poor prognosis with medical therapy, HF therapy, beta blockers, diuresis, or prednisone if acute carditis. Endomyocardial resection with valve replacement or repair. Fabry's, no cure. Treatment with recombinant agalactosidase A, alpha-Gal A, likely require dialysis.